Hello and welcome to today's webinar. I'm Madison Wallace, the project coordinator for the National Association for Children's Behavioral Health, and we're glad that you are able to join us today. We'll begin the webinar in just a few minutes. As you are logging into the webinar, please feel free to share in the chat your name, organization, role, and where you're joining us from. Throughout the webinar, feel free to use the chat feature to share resources and general comments about the webinar. If you have a question, please enter it into the Q&A feature. As time allows, we will address any questions during the Q&A period. To help minimize distractions, please keep your microphones muted until we enter the breakout room period or Q&A time. If you have any technical issues throughout the webinar, please use the chat feature to directly message NACBH staff. We would be happy to assist. I will turn it over to one of today's presenters, Jessica, to get us started.
Hello, everyone. My name is Jessica Gonzalez. I'm the Associate Director from the Mental Health Technology Transfer Center Network, and I'm here today with my colleagues to present on addressing the challenges of recruiting and retaining behavioral health providers. Before we get started here, I want to share just a very quick disclaimer on the next slide that the opinions that are expressed here are the views of the individual speakers and do not reflect the official position of our funder, the Substance Abuse and Mental Health Services Administration, also known as SAMHSA, or the Department of Health and Human Services. On the next slide, I also just quickly want to recognize that our network and speakers strive to use affirming, respectful, and recovery-oriented language in all of our activities. And so the values that you see here on this slide are the values that we will hold throughout today's session. And on the next slide, again, is just another part of our logistics. We wanted to just let everyone know in advance that we will be providing a survey at the end of today's training that we ask you to complete. This is part of a requirement as we are funded through SAMHSA. We provide this training, and as part of receiving the funding, we're required to submit data related to the quality of our event. So we really look forward to receiving your feedback after the learning session today has ended. Okay, so our agenda for today, I will kick us off with a very brief overview of the Mental Health Technology Transfer Center Network, also known as the MHTTC network. I hope that some of you in our audience today have worked with us previously, but if you haven't, I will be providing a very quick overview to share with you what we do, services that we provide, and how to access our trainings and resources. And then we'll officially kick off with the meaty part of our training today. I'll be transitioning it over to some of my colleagues from the Central East MHTTC, who will be focusing their conversation on recruiting a more diverse workforce. And then we'll have it passed over to our colleagues from the Mid-America MHTTC, who will talk through training and retaining behavioral health providers. We'll then go into breakout rooms to allow for you all to kind of spend some more time with our speakers and ask any questions related to the content that they share with you today. We'll all come back together. We'll have a quick Q&A portion, and then we will wrap up with ways to stay connected and continue accessing any of our upcoming learning opportunities that may be of interest to you. So again, a quick moment here to share a little bit about the MHTTC network. We're a network of 11 centers, and we provide free resources, training, and technical assistance to increase the use of evidence-based and promising practices in mental health promotion, treatment, and recovery. 10 of our centers are regionally based. So you'll see here on our beautiful, colorful map, we have 10 centers spread out across our country. And then we have a coordinating office, which is where I come from, making it the 11th center here out of Stanford University. And so our network really works together, again, like I said, to develop resources, training, and technical assistance for the mental health workforce. I invite you to visit our website, mhttcnetwork.org, to learn more about our work, to get connected to the center in your region, And to access all of our free, readily available products and resources, I will plug the link to our website in the chat box now for you all to take a look. If you have not worked with us before, I really, again, encourage you to get connected to us. On the next slide, just a little bit about how we provide training and technical assistance. Our centers work closely with SAMHSA regional directors and state mental health commissioners and local stakeholders to really understand the pressing needs in the region. And we use that information to inform the training and technical assistance that we provide yearly. We have been receiving funding for our MHTTC work for the last 5.5 years. We're currently in our final year of funding, and we'll be wrapping up our work at the end of September. On the next slide, we have just a little bit about our school mental health initiative. So in addition to the main grant that allows us to provide training and TA to the general mental health workforce, we've also been awarded supplemental funding to provide school mental health related training and TA to the school mental health workforce. And we refer to this as our school mental health initiative. On the slide here, you'll see some examples of training and technical assistance that we've provided through this initiative. We provide training, technical assistance, and resources across key school mental health issues, including school violence, suicide prevention, intervention and recovery, the well-being of school mental health providers and educators, and more. Our programming also focuses on the mental health of youth in tribal communities, Black youth, students with disabilities, LGBTQ+ students, Hispanic and Latino students, and others. And aside from virtual and face-to-face trainings and workshops, we also lead learning communities, learning collaboratives. We've developed many courses available online, free of cost, fact sheets, curricula, podcasts, and many other tools to help the school mental health workforce implement evidence-based practices. So again, all of our training, TA activities, and resources are available free of cost to you via our website, mhttcnetwork.org. And so with that, I will wrap up our brief overview of our MHTTC network. If you have any questions regarding our network, you can please plug them into the Q&A box. You can also reach out to me directly. We will be sharing our center's email address at the end of our presentation so that you can reach out with any questions you may have after our session today. But with that, I'll pass it over now to my colleagues, Dave Brown and Raymond Crowell, who will zone in on addressing the challenges of recruiting and retaining behavioral health providers. Dave and Ray, welcome.
Thank you, Jessica. Good afternoon, everyone. Start with maybe a couple of quick introductions. My name is Dr. Raymond Crowell. I'm the clinical director for DANYA, and a job I've held for about a year, just a little less than a year now. And prior to that, I've been the director for the Department of Health and Human Services for Montgomery County, Maryland, and the chief of behavioral health services for that county as well. So a large part of my conversation today with you will be about both the work that we've done and around recruiting and retention of behavioral health providers in Montgomery County, but also what I know from my colleagues across the regions, and mostly across the Eastern Seaboard. So let me stop for a second and allow Dave some airtime to introduce himself.
Hello, everyone. As Raymond shared, my name is Dave Brown, the Senior Associate for School-Based Training and Behavioral Health Equity at the Central East, MHTTC. I also consult around the United States on mental health and suicide prevention and violence prevention as is related to suicidality. A lot of my work is the building that space between self and collective efficacy and moving towards professional behavioral health. Spent a good amount of time both in education, but also in congregate care. So this is really a challenge that we've seen across the last 20 years or so. Glad to be here.
Okay, thanks, Dave. Can we do next slide, please? Thank you very much. So we want to begin with just a few fast facts around this, and I think that represent challenges in our collective capacity to identify and recruit and retain mental health professionals, behavioral health professionals around the country, certainly in the East Coast. And at this point, I'm just going to talk about University of Maryland and Howard universities, but also Catholic University is one of our local universities that trains a great number of social workers every year and psychologists every year. And both of them have reported, all three of them have reported declines in enrollment around 2020 and 2021. I suspect largely due to the pandemic, but also there was a little bit of a decline in enrollment going into that 2020 year as well. But it's showing some rebounding at this point. So, but those gaps meant that there was a drop in the number of social workers that were available for recruitment and hiring, certainly within the county, but across the entire state of Maryland and Virginia and the DC area for a couple of years. I suspect that those drops are replicated in other parts of the country as well. And I'm hoping not in your area, but it certainly has been the case for us. But also some declines, even with the rebound, some declines in the numbers of in admissions numbers, in part because it is compared to enroll applications, in part because it is now more competitive in many respects. One of the challenges that people faced in applying for graduate school, and I think that is affecting our number of students that are available, is the rising cost of graduate education along with existing student loan debt. So folks are coming out of undergraduate degrees with unprecedented amounts of loan debt, of student loan debt, and social work costs. On a quick run through across the country suggested the cost for a complete graduate social work education is varying from $40,000 to almost $90,000 a year for master's level in social work programs. And that's on top of whatever the undergraduate costs are that were incurred, and not including things like supplies and equipment and books and cost of living and fees. So the costs are functionally probably much higher. In psychology, the average cost seems to be running about $115,000 for clinical psychology doctoral programs. And I'm a clinical psychologist by training, and I will tell you that the last time I looked at APA's assessments of the cost of graduate programs, the average cost is actually running closer to about $150,000. And I can tell you that had that been the cost for my degree many years ago, I would probably be a landscape architect or something else in the world that didn't require that kind of expense. I would not have been able to afford that without grants and scholarships and student loans. I graduated with about $18,000 in total debt, just as an example, compared to at least an average now of $50,000, $60,000, $80,000 in student debt that we're seeing is fairly common in graduate students. The other side of that coin is starting salaries. And I'm going to talk mostly about Montgomery County, and this will seem high for some parts of the world. We'll get to that in a second. But Montgomery County, our starting salary for social workers and therapists in 2021 was about $69,000 a year. District of Columbia was running a little bit higher at 81, and Alexandria was a little higher as well at 76. So the average in the region was about $81,000 a year. Next slide, the cost of student debt compared to salaries makes for a hard decision for students. How much can you afford to pay for an education, and how much are you going to get when you come out of school when you graduate? Where are you going to be able to find income that will allow you to have a decent standard of living and pay for your student loans without having to pay for them until you're 60 years old? Salaries. This was especially a problem in the DMV, which is the District Maryland, Virginia. It's a geographic and economic district that we refer to as the DMV, that includes Virginia, West Virginia, Maryland, Delaware, and according to some folks, as far as Philadelphia, including Philadelphia in that region. It makes the starting salaries, being what they are, make retention in the public sector, especially beyond the point of licensure, a challenge for younger professionals. If you started when I did, that number mattered less because I could get a good job and I could afford to pay off my loans in a matter of a few years. But when you do the math, public sector work in in this area versus other locations means that people are moving out of this area to go find jobs elsewhere in the country, which might be good news to some other places with lower cost of living, but not necessarily for us on the East Coast and on the Eastern Seaboard. It also is a challenge for clinicians coming out, for us, public sector versus private practice. We have a lot of mental health professionals in this region, but a good number of them are in private practice, including folks who graduate and join private practices for licensure purposes because the economics are better in the long run. This is a fairly affluent area, so people can afford private practice, which means public sector jobs are hurting. We are hurting for public sector jobs, for recruiting of public sector jobs, I should say. So we have a major recruitment gap across the region. For the Department of Health and Human Services, where I worked for a lot of years, the recruitment of licensed graduate and clinical social workers was challenging precisely because of low starting salaries. And the other piece of this was that Montgomery County has one of the fastest growing, fastest changing demographics of the region. The Chinese and Asian Pacific Islanders represent the fastest growing group in the county. We shifted in Montgomery County from being a majority white community to being majority Spanish community about 5 years ago. We also have a large group of East African community members here, speaking primarily Amharic, but Arabic is also spoken along with Vietnamese. And the professionals in those languages who speak those languages or from those cultures have been historically low, have been incredibly low, which means that we are struggling to try to find ways to maintain some level of some sensitivity around our diversity, to train people appropriately, but also to recruit people who speak the languages of our community. And that has been an ongoing struggle for us and continues to be. Some of the strategies around this, the next slide, that we've used in Montgomery County and around the region. And I'm going to talk a little about some of what we've done, but also some things that I think that providers and local organizations ought to be thinking about, and states ought to be thinking about in terms of how we address some of these gaps. One of the things that we worked on in terms of recruitment and retention for graduate level professionals was raising the minimum starting salary in Montgomery County. And that was actually easier than it looked because of the way the budget office does salary. And I'll bore you with that detail if we need to in the breakout if anybody's interested. But we raised the starting salary by about $8,000 beginning in 2022. And that had the net effect of increasing our recruitment. We would find prior to that, putting out advertisements for vacancies, and we were running anywhere from 100 to 200 vacancies at the height of this. We would get applications back with 1 or 2 applicants, and almost no one who was representative of the cultures that we were in most need of. Changing the salaries, the starting salary, absolutely helped matters for us. So it is one thing that we did, and I will say that we did that without an impact to the budget, in part by juggling how we calculated negotiating with HR to start us at starting closer to a midpoint salary range. The other thing that we offered for all of our graduates and continue to offer is free and continuous education. We have something called the Center for Continuous Learning that recruits and provides continuing education for social work, psychology, licensed professional counselors, and for psychologists. And so that gave us an incentive, provided an incentive for folks to come and to stay with us over time. The other thing that is happening at state level, or has been happening at state level in Maryland, was that Maryland had something called the Health Enterprise Zones, that were offering $25,000 a year for 2 years of service for physicians, physician assistants, and psychiatrists who were serving high-need areas. And high-need areas were both not just Baltimore City, but Charles County and eastern parts and western parts of the state. So there were more rural areas where there was where the enrollment, where the numbers of providers was very light. Governor Hogan ended that program during his term, but it's been reborn now as health equity resource communities under Governor Moore, and we're waiting to see whether or not they will expand the loan assistance support to other professions as well. I think there's some advocacy in play to try to encourage him to do that, so that we can recruit more social workers and give them some loan forgiveness as they or help them with their loans as they join the workforce. We also have been working through Danya with Pennsylvania, and they're exploring supporting BSW programs that are accelerated programs. So you get your bachelor's in social work and then 1 year of additional graduate training to get your master's degree. And they're interested in doing that as a direct pipeline into their services, to create a direct pipeline to service. We in the county and across the state have entered into memoranda of understanding with all the major universities in the area to do internships and practica and to support their students in this part of their training process. But also completing of that internship and practica, we added for anyone who does that in Montgomery County in the Department of Health and Human Services, got an opportunity to be eligible for interview and with recruitment priority. So if we had someone who was really good, they automatically got an interview with us and for a job if they opened up. And a lot of times they got fast-tracked because of their prior experience. Once we decided they were the candidate that we could hire. So it gave them some incentive to come and train with us and some incentive to apply to work with us on the back end. Beyond the graduate level, we have looked at, and I think we need to be looking at as a field, professional service alternatives, things that are foreign trained professionals as an example, but also recruiting out-of-state professionals to work in-state in our programs via telehealth. One of the things that happened during COVID, well, let me back up. 6 years before COVID struck, I was trying my best to engage my practitioners, some therapists in the community and in the county, in doing telehealth and doing mental health via Zoom and via secure internet systems, and could get almost no one who wanted to do that because everybody was afraid of it. COVID comes along, and all of a sudden everybody has to do it as a matter of survival and as a matter of continuing to serve the community. So very quickly we went to telehealth. APA, in its wisdom, gave broad permission for psychologists to practice across state lines so that they could stay in touch with their clients and they could do the work where the work was needed. Coming out of that, and the insurance companies, of course, ramped up their willingness to pay for telehealth and make telehealth a normal part of our operation. So now it's a part of everybody's operation. The thing that APA has done in the wake of COVID was created something called SIPAC. And SIPAC is an agreement between 38 states, right, by my last count, that allows licensed psychologists in any state to practice across those state jurisdictions without having to go and seek reciprocity or without having to become licensed in that state. And I believe that social work as a national bodies of social work and the state boards of social work are trying to do the same thing. So hopefully we'll have that as a capacity. What I haven't seen yet, and this is something that I would have been trying to work on sitting in my old role, is to see whether or not there are SIPAC professionals who are eligible to practice in my state who I can recruit as part of my workforce for some of the work that can be done readily by telehealth. I think there is nothing that I see other than perhaps some policy at the local level and maybe some agreements with state that would stop us from hiring SIPAC eligible people in South Carolina, for example, to work in Maryland and to do some work in some of our clinics in Maryland. So I think that is something that that's an approach I hope that people will take on and tackle in the coming years. The other thing is the use of foreign trained professionals. We have a variety of professionals that are immigrating to this country who were trained as social workers and psychologists and physicians and nurses in other countries with different systems, but don't meet licensing criteria in America. So in Montgomery County, we created the Welcome Back Center of suburban Maryland that was designed specifically to help retrain foreign trained professionals in psychology and social work, and in medicine and in nursing, by offering them practica, by offering them guidance on what fields they can meet criteria for. So we had physicians who were then retraining to become nurses, retraining to become psychologists or social workers so that they can re-enter the field. So welcome back to the field is what the Welcome Back Center is all about. And that has helped through a lot of work. They recruited, they gained access to the county systems, and we'll talk about recruitment. And we were able to recruit them into the county system as employees, pending some of their completion of training. But we also engaged with Johns Hopkins, Shepherd Pratt, Holy Cross Hospital, a number of suburban hospitals who were providing mental health services in the community, to take them on as interns and practicum students and allow them to get trained to facilitate their training. Next slide, please. And let's see. So this issue of using Welcome Back, we were able to find strategies, positions in the county that they were eligible for, and hire them into those positions, which started them back and got them back into the field. We also, the other thing we are seeing nationwide now is the use of peer recovery specialists and certification training of peer recovery specialists to provide base level services for folks who are in recovery, both on mental health and on substance abuse sides. The state of Maryland is doing and sponsoring certification training so that they can meet standards to be certified as peer recovery specialists. And before I left, and I think they are still working on this if they haven't actually done it at this point, looking to find ways to reimburse providers for the time for the work done by peer recovery specialists, which gives us both a vehicle for payment, but also a way to tap into a certification process for folks who have lived experience and who are from the communities that we're most interested in serving, in most need of service. The promotores is another long-standing tradition in the Latino community, but we've broadened that out to include other communities and focused on behavioral health, where we're training them in core behavioral health principles and techniques that they can do without licensure in the community. I have AKA neighborhood liaisons here. This model goes back almost 20 years now to at least one in Baltimore, where we hired folks with high school and AA degrees or BA degrees to serve, who lived in the communities that we were serving, trained them and made them part of the Hopkins faculty, and gave them permission to do and support to do basic level community-based work, and to serve as bridges back to professionals to master's and graduate level professionals in the field. That there is a great deal of research on the outcomes of that's available to folks if they're interested in it. But it's a workable model that has continued to live and exist across the country. The other thing for us that's important for us to look at is long-term recruitment strategies in the community, high schools, community college, high schools, junior college, and out of the community. One of the challenges about immigration in Montgomery County, and one of the pluses, is that the communities come with a variety of people who have interest and skills in human services, and our job is to figure out how do we bring them on board, engage them, and get them into the field, into the pipeline. So reaching out to high schools, to junior colleges, to identify people who speak Amharic, who speak Spanish, who are Chinese born, to get them into the workforce at whatever level we get them into the workforce, and then to use their skills in serving the community. One of the things that we've done at high school level was offer community service hours in human service settings, just to pique the interest of high school students in going to junior college or going to one of the local universities or joining the workforce at whatever level and then matriculating through the system. Something that isn't in the slides, and I didn't have time to really talk about it, was the use of alternative approaches to treatment. And the one that I have enjoyed watching the evolution of is something called the friendship bench, which originated out of, I believe, Zimbabwe, but has been imported to London and to New York as a model that uses indigenous people, uses older people from the culture, older adults from the culture with training to be available resources in the community, akin to neighborhood liaisons and maybe perhaps promotores, but with a different bent. Folks who speak the language, who are sitting and having a casual conversation with folks, but who also happen to have some training to back up that conversation with folks. That has shown at least some preliminary results in terms of savings of deeper level involvement in the behavioral health system, such as psychiatric hospitalization. The other thing is administrative policy changes that we think that we've looked at and that other communities and providers need to look at. Creating career paths to professional degrees. So if we're hiring someone who's a neighborhood liaison or we're hiring them as a case manager or a behavioral health technician, supporting their growth professionally through graduate school, through undergraduate school, through tuition support or tuition reimbursement has been a useful strategy. The other piece of this is creating promotional opportunities. So we created a track in Health and Human Services. We had a position called Behavioral Health Technician that was someone who was pre-master's degree, that once you got your master's degree, you were eligible to apply to become a Therapist 1, which is a therapist without a license. But on completion of your license, you were automatically promoted to the next level of Therapist 2. So you got a challenge, you get a pathway that guarantees that as you graduate and move to higher levels of training, you're automatically eligible for promotion to the next level up. And then the other piece is, I think I said this earlier, the reimbursement of paraprofessionals under Medicaid, state Medicaid, and hopefully under insurance at some point, private insurance at some point, gives us an opportunity and a window to recruit a more diverse group of practitioners in the field. So I'm going to stop there and turn this over to Dave to take us out and add any comments on anything that I've missed. So Dave?
Thank you, Raymond. I think you covered a lot of it. I had hoped to share a slide from the National Institute for Healthcare Management, which really covers a lot of this. It talks about how to increase capacity, the resources, the human capacity, but also at the same time decreasing the need for crisis-based services. So it's addressing mental health disparities at the early stages. Some of the things you talk about, peer recovery specialists, community health workers, training people in the community, even parents, school systems, and things like, whether it's mental health first aid or other resources, so they can be the real first responders. And then you build in programs, sort of these near peer programs that are supporting mental health. And then you have high school students supporting elementary and middle school students, and then colleges and universities supporting mental health and education in these, and then all the way up to, higher education. So it's not only creating your work, recruitment pipeline, but reducing some of the stigma as well. So we can't just look at sort of these linear approaches to increasing the workforce, but decreasing the stress on the workforce, which has been a really, really important. I mean, sometimes people don't choose going into the public sphere because of the workload associated with the salary. That sometimes, you know, from the HR standpoint, that salary doesn't always indicate where someone goes to. It's that work-life balance. We need to identify mental health earlier on, invest in stakeholder engagement, and really rethink what evidence-based practices are defined as. Like Raymond mentioned, Los Promotores and other programs in the terms of positive deviance and what is working well, not just to not have people be sick, but promotes health, welfare, and safety. That's that health promotion, because prevention is still prevention of harm. And in many communities, the only time they'll see a clinician or see a doctor is if there's a crisis. So their relationships to institution is always illness focused. That's where we want to prioritize and health, destigmatize healthcare, really talk about its human health. There really is no difference between mental and physical health. There's only human health. And then building relationships on that professional and personal level, not just when someone's sick, but promoting health. Raymond mentioned telehealth, and the one piece that's not mentioned as often is how AI, artificial intelligence, will be used in the future. And there's some great early research and articles out there that said it's not meant to replace professionals, rather it's helped to identify patterns so that we can really get in earlier when we're seeing patterns of increased problems, whether it's by zip code, by street, or within certain populations. And then how do we really sort of marshal resources earlier on so that we're not always crisis focused. And then Raymond really identified well how we expand workforce capacity, provide a continuum of mental health support services, redefining what professionals are. And the last one is really to explore complementary approaches to mental health. Again, that you know, health is not necessarily the absence of illness, but sort of that strength, knowledge, capacity, and ability to lead one's life the best one can, regardless of illness, whether it's somatic or mental, whether it's a mental illness. So I think we covered a lot, and I think we're running out of time, but I'll leave it at that, and be happy to have discussions with anybody later on.
Awesome. Thank you so much, Dave, and thank you, Ray. I know that you both will be holding a breakout room later today, and so those in the audience who are interested in learning more about the content that Dave and Ray have just shared with us, or if you have any questions related to their content, we'll ask you to jump into their breakout room when we launch those in just a bit. And we are keeping track of questions that are being asked in the Q&A box. If you have any other questions that you want to make sure you jot down now so that we keep those in mind for the Q&A portion of our session today, I encourage you to please enter those in the Q&A box. Please know that we're monitoring those and we'll be responding to them at the end of our session today. So next we have Brandy Clark, who will discuss recruitment and retention of behavioral health workforce, building a pipeline. Take it away, Brandy.
Thank you, Jessica. Thank you, David and Raymond, for the comprehensive overview of a lot of really great strategies. I think what I will be able to speak to, and my colleague, Dr. Doyle, will be able to speak to, are really how we've applied some of these in a specific way. So maybe some exemplars in terms of how we built training pipelines, but also then workforce development and legislative work that's helped to sustain it. So my name is Brandy Clark, and I am the project director of our Mid-America Mental Health Technology Transfer Center, but I'm also the director of our department here at the Monroe-Meyer Institute at the University of Nebraska Medical Center. And so what I'm going to share or speak to today, if we can go to our next slide, is a little bit about how have we worked to recruit and retain a workforce in this area, especially given that we are represent a pretty big mental health professional shortage within our state. If you see us right there in the middle of that map, the gray area represents those areas that would be considered non-shortage areas, but the majority of our state would be. And you can see the 4-state region that we cover, Iowa, Nebraska, Kansas, and Missouri. A lot of our states are blue, and meaning that recruitment into our regions is pretty important. We need more providers. And so looking at ways that we do that, we have to get creative. We're not a coastal state. And so how do we attract people to come and stay and work here? Next slide. I can say that, speaking for myself, I am somebody that kind of represents how this model works. I'm not from Nebraska, yet I have now lived in Nebraska longer than I have the Northwest, which is where I'm originally from. I trained here and I stayed here. And this is kind of a testament to how our training model here works. So the model that I'm speaking to today is our Nebraska PICT model, or our Nebraska Primary Integrated Care Training Model, and how we've kind of built this training pipeline to attract folks to the state of Nebraska and then also keep them here. When our program originally started in 1997, it was one outreach clinic in one of our rural communities. And we've since expanded that to over 40 plus clinics throughout the state. And we've become a member of one of the largest internship training programs nationwide. I do have a short video that we'll watch that kind of explains that history far better than I can. Over the time in our training program, we've had hundreds of predoctoral interns, hundreds of master's level interns, and doctoral fellows. I'd say in a given year, we train anywhere from 60 to 80 trainees, and we tend to retain about 30 to 40% of those to the state, which is huge for us and our biggest recruitment tool. So here we'll watch this video here that explains a little bit about how the Nebraska Internship Consortium of Professional Psychology works on our next slide, and give you a little bit of that history for how it was built and how it expanded.
Hello, I'm Beth Dahl, and the training director of the Nebraska Internship Consortium in Professional Psychology. We are the oldest and largest internship consortium accredited by the American Psychological Association. Every year, since 1985, we have brought doctoral candidates to Nebraska to complete our highly acclaimed internship in professional psychology.
So my name is Zach Bessaker. I work at Creighton University over in Omaha. And one thing that I really like about the consortium is the opportunity to connect with other interns who are at different sites. It's really nice to be able to share experiences, some that are similar and some that are different, and get that opportunity to both socialize and learn in kind of a collaborative environment like this.
The consortium began when Dr. Jane Close Conley, a faculty member in educational psychology, convinced 3 Nebraska mental health agencies to band together and offer an internship stipend and substantial supervision to the department's advanced students in professional psychology. Within 5 years, 30 interns had completed an NICPP internship at one of the 13 different agencies. Today, more than 40 interns annually complete their accredited internship at one of our 8 NICPP member agencies: Boys Town, the Department of Health and Human Services of Nebraska, Catholic Social Services, Creighton University Center for Health and Counseling, the University of Nebraska-Lincoln's Counseling and Psychological Services, the Monroe-Meyer Institute of the University of Nebraska Medical Center, the Psychology Department of Nebraska Medicine, and Quality Living Incorporated of Omaha. You can find a virtual open house for each of our member agencies on this website under the Consortium Sites tab. In every case, NICPP interns are supervised by highly qualified licensed psychologists.
So my name is Jasmine Gray, and I am completing my internship with the Monroe-Meyer Institute under the Comprehensive School-Based Mental Health track. And my experience thus far has been pretty amazing. The supervisors that I've had the pleasure of working with have been extremely supportive, from my direct supervisors all the way up to the director of training, Dr. Allison Grinnan, as well as Dr. Beth Dahl. Just the communication, the support, overall climate in general is just amazing here. Open door policies, I'm able to go in and pretty much talk about and express any concerns that I have. I feel extremely supported here, and so it's been amazing thus far.
Specific clinical opportunities will vary from one site to the next, and so I encourage you to visit each site's webpage. Indeed, our consortium structure allows us to provide unique opportunities for residential and community-based services in medical or community agencies, within remote rural or culturally diverse urban communities, and with Nebraska's indigenous communities. Through site visits and monthly seminars, we are able to create a collaborative community of interns and supervisors across all 8 of our member agencies.
I'm Kayla Frodsham at QLI in Omaha, Nebraska. And that's a post-hospital rehabilitation center. And to be honest, I don't think I could have picked a better internship. It's such a good match, and not only do I love the team aspect at QLI, but I've learned so much about brain injury and clinical skills. It was my top choice, and I got it, and I wouldn't change anything about it.
At the NACBH Central Office, I work closely with Elisa Kushner to make certain that every intern accrues the carefully documented hours, experiences, and stellar supervision required to meet national standards in professional psychology.
Hi there, I am Elisa Kushner. I'm the program coordinator of the NACBH. I work closely with our training director, Beth Dahl, and our supervisors to make sure we run things smoothly and according to APA standards. I also work closely with each intern to make sure they are completing the necessary tasks so that they can successfully graduate from our program. Our site has grown to be the largest internship site in the USA. We are proud of that and proud of the multitude of experiences that each intern can gain when they become a part of our consortium.
I'm placed at Creighton University's Student Counseling Center, and I really enjoy it. It's a fast-paced environment with some really great folks. We get lots of training opportunities, and we get to work with students both undergrad and grad, so there's a wide range of students who come in with a lot of different presenting problems, and it's exciting to be there. And we also have a therapy dog, which is really enjoyable.
This year, we anticipate awarding certificates of internship completion to 48 NACBH interns who are completing our advanced professional training. They will go on to become highly skilled professional psychologists.
Thank you. We'll go to the next slide. What I wanted to reflect in that video was the power of collaborative partnerships and the way that that's helped us to expand and attract trainees. We've also been able to do this work through workforce training funds, legislative funds that my colleague will speak to here in just a moment, but also graduate training programs through HRSA, the U.S. Department of Education, and our LEND training programs have helped to fund and expand our growing programs. Next slide, please. When I mentioned our first clinic in 1997, we probably had a faculty of maybe 4 to 5 members, and we are now at a faculty of 22. A faculty on in our department. We've also expanded our areas of training from what we would have considered child and adolescent psychology to include integrated primary care, an ABA psych track, a school mental health program, a lifespan program, and our rural behavioral health program. So our growth has really allowed us to expand to other areas of emphasis as well. Next slide. The other part in the work that we have done is to try to also promote and disseminate how to build these pipeline programs. A lot of the alumni from our training programs, if they don't stay here, have gone off to other academic medical centers and started their own training programs. And we've worked through consultation and technical assistance to help them begin their own pipeline programs. One nice example in our Wayne State program, we partnered with them to build a school mental health training program. And in the last 5 years, they've retained 17 of their trainees to stay within their rural school districts, which was a tremendous growth for them. Next slide, please. The one thing that we still recognize, even with the successes we've had with recruitment, is that recruiting to our rural communities can still be a challenge. And that post-COVID, we used to be able to recruit 4 to 5 trainees per year. We're getting closer now to 1 to 2. Still able to do so, but it's become a little bit more difficult. Big efforts on our part are to grow our own and recruit locally. So keeping folks within their communities to train in their communities where we want to keep them. We look to also model success by having them train with supervisors who live in their communities so they can see what it's like to be those providers. And then also to promote what we call a stickiness factor and build partnerships with community organizations that would support retention. One of those things that we're looking into now is how we might also be able to look into housing options with some of our community organizations. Next slide, please. We're going to get to some opportunity to speak with you more in depth about how the pipeline program has worked for us and how that's been built. If you have questions, please provide those. And also in the breakout sessions. But I want to turn it over to Dr. Doyle at this point, who's going to talk a little bit more about what work has been done for workforce development and also some policy work to support legislative changes in the state.
Thank you so much, Dr. Clark. As Dr. Clark mentioned, my name is Dr. Marley Doyle. I am the director of the Behavioral Health Education Center of Nebraska, which we refer to as Beacon. And so I'll be referring to it as that from here on out because it's shorter. I'm a psychiatrist by training, and I've been in this director role for about 5 years and have the clinical background of women's mental health. And I am also a testament to someone who settled in Nebraska but didn't grow up in Nebraska. So I came here for part of my schooling and then returned because of the people and the experiences I had had. So kind of speaking to that model about relationship building as being a tenet in any recruitment and retention strategy. Next slide. Okay, so I just want to give a little bit of background about Beacon and how we were founded. So much like you saw in the map that Dr. Clark showed, Nebraska and the Midwest in general really struggle more so with recruitment because the geographic location and the population is not as dense as some other states that are coastal or just smaller states that have a more dense population. And so we've struggled with workforce shortages for quite some time. And our legislative body in 2009 reached a point where there was a little bit of a crisis, especially in regards to child and adolescent providers. So it came to the attention of the legislature that there were long wait times and there were families that were desperate and didn't have anywhere to turn for behavioral health services. And so Beacon was founded out of that. And there was a group of people from the University of Nebraska Medical Center who thought of this idea of having a state-funded workforce center and then got legislative funding to be able to do so. And so when they started, the charge was really focused on child and adolescent psychiatrists was kind of where it started. And then from there, it was kind of psychiatry in rural areas. And since 2009, we have really expanded to include all of the behavioral health workforce. And so we're proud of that fact. And we've had additional supplemental legislative funding to support different areas of the workforce. So we've really kind of evolved, I would say, from the time that we started. And it's been interesting to kind of see how that's impacted the workforce across the state. And Beacon continues to be housed at the University of Nebraska Medical Center, though we serve the whole state. So this is where our home is, an academic medical center, but our we really make sure that we are not just tied to one institution or part of the state. We really focus on being statewide. Next slide. Okay, so since we were developed, we've kind of made a model of behavioral health workforce development. And I'll talk a little bit about the model here in a second. And since that time, we have so many lessons learned. And I think that that's what has been attractive to some other states. So we have worked with other states in the past few years who have reached out to us and said, you know, we're having these shortages. How have you guys approached it? Can we learn from your experiences? And we are happy to do that, because if we can come up with a strategy that we know works, we'd rather states start from a place with a model that has been proven to work, rather than trying to kind of build the plane as you fly it. Now, sometimes that's how innovation happens, and we've done plenty of that. But if we can help other states kind of develop a model that's specific to their needs, then we are happy to do it. So why do states kind of reach out to us? Well, I won't go too much into this today, but since Beacon was founded in 2009, we've actually seen an increase in our behavioral health workforce by about 44%, which is an anomaly. Most states nationwide have plateaued. Most rural states have decreased. And so we're a little bit of an anomaly from the fact that we've increased. Now, that's not to say we've solved the workforce crisis. We still have a lot of disparity between rural and urban. We still only have about 50% of the providers that we actually need. And we, have seen an increase in some disciplines more than others. So it's not by any means to say that we've solved it, but maybe we are doing things to kind of tip it in a direction that is positive. Next slide. Okay, so what is the model that we've developed? And so I have it here in kind of this infographic, and I'll talk about each of these. So you'll kind of notice that there's these 6 tenets that we have used, and none of them actually use the words recruitment or retention. And we certainly have had programs that have focused on recruitment and retention, but what we found is that you really need to define what you're talking about. So what is recruitment exactly, and what is retention exactly? And what are the components of that make for successful strategies? So on this graphic, the top, I would say if you kind of had to simplify it, the top 2 tenets are kind of more what we would traditionally refer to as recruitment. The middle arms there are more what we would traditionally refer to as retention. And then I would say the bottom 2 tenets are what we would kind of refer to as sustainability, for lack of a better term. And so that's kind of how we have conceptualized the workforce development model that we have done. Next slide. So here's just a little bit more description of each of the tenets. And so the top 2, what I kind of referred to as the traditional recruitment, are career awareness and career preparation. And so we have programming for each of these tenets that I could probably talk for an hour about each of them. But generally they fit into these categories. So career awareness is making sure that students know that behavioral health is actually a career that they can do. A lot of times, even when we go into undergraduate, they will kind of say, I didn't know you could do that, or I didn't know that was a career. And sometimes this even comes from like psychology majors, right? They just aren't sure what options are available to them. They may have had exposure to one track, right? And so then when you kind of say, well, there's these other things you can do, it can be very eye-opening. So the awareness piece is important. We do a lot of work with undergrads. We do some with high school students, and career panels and mentoring programs, that sort of thing, really to kind of just get students to know about us. The career preparation is the next stage. So these are students that are intending to go into a behavioral health field. We help them get there. So we have a mentoring program, we have a scholars program, we have a student advisory board. We really try to make sure that they know exactly what they need to do. They have the support that they need to do it, and that we are trying to work with our academic partners across the state so that we can bolster these students and get them where they need to go, and hopefully training in the area that they want to practice. What we kind of see in our state is that a lot of kids from rural areas are forced to come east, right, which is where our urban centers are, when in reality it would be much better if they could do their training in the area that they want to be, which is their hometown. And then the second 2 bullets are kind of the retention piece. So this is like the training and experiences. Just in short, Beacon does a lot of direct support of behavioral health trainees, anywhere from graduate to postgraduate trainees. We really try to prioritize experiences that are in urban or rural areas, traditionally underserved areas. And we really try to make sure that these trainees have exposure to that and good mentorship, and with the hope that then they will go and practice. The other piece is the lifelong learning. And this is kind of helping licensed professionals be able to kind of continue to do the work that they do. So continuing education credit, support, networking, that sort of thing. And that has been kind of the way that we've termed it. It's really been a nice program, and we're trying to do more of that as professionals are burning out, as we all know. And then the sustainability pieces I won't talk about too much today because that's not the topic of this workshop, but you have to study what you're doing and you have to have partners. And so we do research so we can track what we're doing, we can evaluate our programs, figure out what's most successful so we can continue to implement the successful programs. And then the collaboration is key because you can't do any of this in a vacuum, especially when you're doing statewide work. You need local partners to be able to do it. Next slide, please. Okay, with that, this is kind of just to show you that we've expanded across the state as well. So we do have these sites that we've replicated so they can do this workforce development work on a local level in partnership with Beacon overall. So this is another strategy that we've developed that's been pretty successful in making sure that the workforce strategies meet the needs of the geographic areas. Next slide. All right, and with that, I'll stop because I know that we want to have time for questions and breakout sessions, but here's how you can find us, and I'm happy to answer more questions as we get into the breakout. Thank you.
All right, guys, we got kicked out, yanked out.
Hello, everyone. It seems like we're all back in the main space. I really hope that the breakout time was helpful to you. If you had specific questions for Brandy and Marley and Dave and Ray, I think that some of our other participants dropped off. Maybe they didn't have any questions going into the breakout space. But now that we're all back together, Madison and I just wanted to open it up for general Q&A. If there are any questions that you still had that maybe you didn't have time to address in the breakout space, or anything that came to mind for you as you were having discussions in that breakout space, now would be the time to unmute yourself and share any comments, questions, any other remarks you might want to share in this space.
Real quick, Joanna, you were saying something right there at the end of our conversation about folks not wanting school-based placements necessarily. So one of the things that we've done within our internship is create rotations, but not placements in schools. So folks can learn to work with schools and in schools, but also outside of schools at the same time, to realize the flexibility of their degrees or their license and how they can utilize it. And actually, we've had a lot of people who are really attracted to that option. They're like, ooh, I can work with schools, but I don't have to be in schools all the time. Yes, you can. And also you can work in diagnostic clinics. You can work in therapy clinics. You can work in pediatric clinics. So giving them flexibility in rotations is one of the ways we've actually recruited. And just knowing that it was an option, we've actually now had people ask, well, can I do a rotation in the schools while also not in the schools? So we've created flexibility that way to help recruit more folks to see, yes, there's roles for you. It doesn't have to be an all or none.
Mm-hmm.
Yeah, we have 8 outpatient clinics, so we've benefited from that too, where we've been able to have a couple days in school for interns and then also for our employees too. So someone works from home on Fridays doing telehealth, but they're in the school other days of the week, and that's been beneficial. But it used to be that school-based scheduling was just amazing, right? Like I could work in a school and then I'd be done by 3, and now it's like, well, why would I work in a school when I can do telehealth and be home all day? And that's been a real real challenge. And the acuity of kids is different. I mean, we've heard nothing but how the acuity of children and how challenging that's become, where, you know, a normal school day doesn't look like a normal school day anymore.
Schools have lost a lot of the supports they used to have. So the things we relied on in terms of those partnerships where we were one of a team, we were one team member that was supporting a child, we find we're often like begging for support. They've just lost a lot.
We are seeing more co-location of services, you know, so that it's not just a school-based. And I believe that the Medicaid, Medicare are funding some different services as well that are earlier on, even some trauma-informed services that aren't linked to special ed services. And that is seen more in community schools. So you can have those partnerships that aren't just funded by the school system itself that helps.
Yeah. I think the other thing that our schools are learning more about, it is, I will say it's not perfect yet, but we're working at it, is that schools can actually be credentialed sites for billing. I didn't know they could be in the past, but then the side about operating that, like, well, who manages the billing and all of those things too. So we've been working a lot with school districts to build their capacity so they could have more braided funds. And so not just with Medicaid funds, but actual billing private insurance to provide service. It comes with challenges then in terms of what schools offer and who they offer it to or how it's funded. You can't require somebody get therapy they have to pay for necessarily, but you can offer it. It does take some capacity building.
When I was at Hopkins, Brandy, we did school-based mental health services, and we braided funding. The schools put in some money from their administrative claiming from Medicaid to fund school mental health services so we could make it available to everyone. Plus, we also billed Medicaid at the state level for the service. Both the school providing the therapist and the mental health system providing therapists located in the school. So there are a couple of different ways that we've approached it. So it's good to hear somebody else is doing it.
Yeah, the exact same. Yes. The one thing I will say that, and I'll stand on this soapbox all day, is that therapy service without also consultation is not as effective. If those people coming in and providing services or from the community aren't also integrated into the school system, you'll often hear complaints about it not working well.
Yes.
They need to be integrated. They need to be on the consultation teams. They need to be part of the planning for how things will look and work so that they understand the system that they're into. And that's when we contract, it's always written, yes, we will provide the service, but also we want to be part of your tier 1 teams. We want to be part of the planning teams and provide that consultation. And that's part of that braided funding that you talked about, where that comes from.
I'm smiling because that sounds exactly like our experience in Baltimore. Our first year in, they weren't a part of the team, and the principals at the end of the year ripped us apart for it. And so we did contracts and agreements, service level agreements with every school that we went into that required that person be part of the team. So they were coming in from the outside, but they were absolutely a part of the team. And at least a portion of their time was spent not in direct service, but in consultation to teachers. So classroom observation and assistance to help teachers figure out how to do a better job with challenging kids in their classroom. So it made them invaluable to the teachers.
Thank you, Ray. Thank you, Brandy. Any other last minute questions or comments from anyone in the audience? Okay, well, Madison, if you don't mind pulling the slides back up, we just have a couple of closing remarks and reminders before we officially wrap up today. I really hope that the information shared today has been helpful, and I want to remind you that you can access other virtual learning opportunities and resources on our MHTTC website. We have a training and events calendar that outlines all of our upcoming learning opportunities that are free of cost to you, that you are able to access as you wish. We also have a product and resource catalog, and this holds all of the products and resources that we have developed in the last 5.5 years that, again, are free of cost to you for you to download, share with your colleagues, etc. So really, again, encourage you to visit our website to learn more and to get connected to the MHTTC Regional Center that serves your state. If you have questions about today's presentation or about any of the other learning opportunities that the MHTTC network is hosting this summer, that again are available free of cost, we have our email address on the slide here, and you can reach out. This is our general email address, and I monitor this email address along with my colleagues at the network coordinating office. And so we help everyone get connected to the MHTTC that serves your state, especially if you have a specific request for technical assistance. And before I pass it over to Madison, who will officially wrap us up here today, I also want to share another resource. I mentioned earlier that the MHTTC network is going to be wrapping up our grant at the end of September. And so a lot of folks are asking us, you know, what other training and technical assistance centers can they turn to for some additional support and training? And so I wanted to call out our funder. SAMHSA has a practitioner training page on their website. And so there they list all of the TTA centers that they fund that provide practitioner training across the topics of mental health and substance use. And so really encourage you to visit their website. I can plug the link for that in the chat box. And again, you'll be getting a copy of these slides and the recording. And so you'll be able to access that there as well. Last but not least, we do have a survey that we ask you to complete. It's about 3 minutes, and it really helps us to understand, you know, how we're doing in leading these trainings, and any feedback that you might have for our colleagues here who presented today would be very much appreciated. Madison will be sending out the link for that in a follow-up email. We also have the QR code here if you wanted to quickly scan that before logging out of the room today. So with that, I'll pass it over to Madison. Thank you, Madison, for having us here today. We really appreciate the opportunity to collaborate with you and NACBH.
Thank you so much, Jessica. Before we conclude today's session, on behalf of NACBH, I would like to extend our sincere gratitude to our presenters one last time. And to all of the attendees today, we appreciate you spending this hour and a half with us. Your active participation has been invaluable, and we hope that you found the discussion not only informative, but also actionable. The webinar slides and the recording will be posted within 1 week to the On Demand Learning Center, as well as shared via email with all webinar registrants. We hope you'll make plans to join us for some of our upcoming webinars. For more information, you can visit www.nacbh.org/webinars for more details. And then, until then, we hope you have a wonderful day. Thank you all. Bye-bye.
Thank you.